afternoon, everybody. It's a real pleasure to be here today and speaking to the community of rare diseases out in Singapore. My name is Rick. I am CEO of a patient organisation based in the UK called Beacon for Rare Diseases, and we were previously known as Find a Cure just a month ago. What we do as a group is try and find ways to work really effectively with existing patient groups and newly forming patient groups. We want to help those groups to form, grow and professionalise. And in this work, I get to work with a real breadth of different organisations across the rare disease space, mainly in the UK, but increasingly spread across the world. So what I'm going to be talking to you about today, and hopefully as you see from these slides, is why rarity matters, and why it matters on a local scale and a global scale. And hopefully the experiences I've had in the last 7 years working with Beacon in the rare disease field will give you some insights to help you really appreciate the impact of the work that you're doing and that everyone in the rare community is trying to do together. So why does rarity matter? And there's a huge number of reasons for this. But firstly, it matters because of the impact on the individuals and people who are affected by rare disease. And essentially, rare diseases lead to isolation. And isolation is something that's to be broken and prevented at all costs. What we say at Beacon is we want no one to experience their rare journey alone. No one should have to walk the pathway of understanding complex rare genetic disorder simply because no one can go out there and find the research to help them. They should always have somewhere they can turn. Rare diseases are fundamentally isolating. It can take a prolonged period to secure the diagnosis you need to actually understand what's going on with your system. Multiple misdiagnoses are a really common experience, and even at that point of diagnosis, many patients still are receiving that information as a printout from Google and being told that there's nothing we can do, there's no care pathway, there are no experts, you won't ever meet anyone else with your condition. Go away and deal with that. And that's something I've heard from patients globally. It doesn't matter whether you're based in Kenya, in Singapore or the UK, there's always a high chance you'll have that experience, and that is not good enough. Secondly, rare diseases are isolated because there's a very small number of treatments available. And if you haven't got treatment, it can be really hard to know what you're going to be able to achieve and what your prospects and prognosis looks like. It's an outcome which is really disempowering to the patient, especially when there's no actual research going on for the condition either. This is a deeply isolating problem. And thirdly, rare diseases fundamentally isolate the way you engage with the world around you, with the society. We know that people living with rare conditions often struggle to hold down paid employment, to secure the education they deserve, or even just simply tap in to the widely available social support that might be there in their community. And this all leads patients to feel isolated, alone, living with very complex medical needs. At this time in the world, when COVID is coming towards the end of the global pandemic, hopefully, there is a real understanding of the impact of isolation on individuals, their mental health and well-being. Rare disease patients have been living with these challenges for generations, but right now there's a moment when we can spread this message and be better understood by the world. And it's important what we're doing today and what you're doing on Rare Disease Day to make that message heard. Rare diseases matter essentially also because there's a lack of equity in care. If you have a rare disease, you will almost certainly receive lesser quality healthcare than you would receive otherwise. And that's not something that's acceptable. We should all believe that there should be equal access and fair access to healthcare regardless of your condition. And I hope that you can receive support from a medical professional. And that isn't something we've seen enough in rare diseases. We need to make sure as societies that we're living to that standard. Rare diseases matter because they're often at the forefront of medical innovation. We've seen in the last 5 years a growth in the delivery and development of gene therapies, gene editing technologies are on the horizon as well. And in almost all cases, these therapies that have reached market and those that have been developed are working in rare genetic disorders, which have been identified and diagnosed through the genomic revolution. Put simply, the biggest cutting-edge development in modern medicine, genomics and gene science, is targeted precisely at the 80% of rare diseases that have a genetic basis. Medicine will move towards working with small populations, whether subsets of large diseases or hopefully rare diseases. So rare matters because in many ways it's the future of medicine. And finally, and I think most importantly, rare matters because of the patient engagement and patient community. In rare diseases, we've had to find a way to do things differently because we haven't been noticed and haven't been a high priority for many, many years. And the way we've done things differently is by bringing together a community of people, either in a country or globally, generally through social media, to share their experiences and drive forward as advocates to deliver change. And this method, putting patients at the heart of drug development, of care provision, and of planning of society's response to rare diseases, is actually something that's beginning to be rolled out into the wider field of medicine. Rare is leading the way in how we should be thinking about developing medicines with patients at its heart. Patient groups really do matter. They connect and support people living with a rare condition with one another, so they can see other people who have the same experience of life as them. They provide the driving force behind research by identifying new researchers who could help in a rare condition and actually connecting them together, often also funding early stage research. And they can advocate for change in their rare condition to drive changes in policy. Patient groups really understand their rare condition because they're run by people who are affected by it. And this is a crucial point. They actually know what the impact of a rare condition is day to day and what needs to change. And this gives them the energy and the impetus to drive the change, just like you in the Rare Disorders Singapore community will fully understand. Some examples that I've worked with, one here is the CATS Foundation here in the UK. In 2010, there was no charity for Tay-Sachs disease or Sandoff disease. In 2011, Dan and Patricia Lee's daughter, Amelie, was diagnosed with Tay-Sachs. And upon that diagnosis, they decided to form an organisation to pull together the patient community of Tay-Sachs in the UK and beyond. Initially, they were just looking to connect patients, but they quickly realised the need to provide support for those families, to provide conferences, to bring together the research and patient communities in Tay-Sachs to drive it forward. They identified potential researchers they could work with to get involved in gene therapies and drug repurposing, and built a registry to understand the life history of the disease. Thanks to their work, there are now multiple different drug development projects for Tay-Sachs around Europe. That was sadly not enough to impact the life of their daughter Amelie, who passed away a few years ago, but it has made a huge difference to the Tay-Sachs community and gives them hope of a better future for people born with Tay-Sachs. Another example is the AKU Society, the group I've worked with extensively during my time at Beacon. The AKU Society represent a rare disease called alkaptonuria, or black bone disease, which essentially leads to a degradation of the bone and cartilage in the body when patients reach middle age. And this leads to a very severe form of osteoarthritis. What the AKU Society knew when they formed in the UK was there had been a failed trial for a drug in the US, but that trial really failed due to poor endpoint selection rather than the biochemistry behind the drug, which was very self-explanatory. It should impact the pathway. And they decided to have another go. They decided to use all their resources, effort and drive to try and get this drug approved for their rare condition. They did this by conducting extensive research. They conducted the first human autopsy of an AKU patient to understand the condition. They developed a mouse model for AKU. They developed their own clinical endpoint, an AKU severity score, to better assess disease progress in AKU patients. They managed to secure a specialist centre for treatment of AKU in the UK NHS that prescribed the drug called nitisinone off-label into patients because the logic for it was so robust. They then went and built an international consortium, including a pharma company, CROs, multiple hospitals around Europe to run a clinical trial. They secured funding from the European Union to deliver that trial, over 6 million euros to run that trial over 5 years. And using that, they ran a phase 2 and phase 3 study of this condition. They were able to recruit over 140 patients into that phase 3 study for a disease which is about 1 in 500,000, 1 in 250,000 prevalence. So normally you'd expect a clinical trial with 40 odd patients. And that trial was successful. They've reached their endpoints and they've now managed to secure approval in Europe for the licensing of nitisinone for alkaptonuria, and patients are receiving that in multiple countries across Europe and in America as well, I believe. This is a huge example of what a patient group can achieve to drive forward the situation in their rare condition. But it's crucial to note that it isn't just research and treatments that matter. In all cases, patient groups can help move the dial in the care and the connections between patients and the rare community. The reality for most patient groups is that they aren't at this scale. They're small, they're volunteer run. They're run by people who either live with the condition or care for someone with the condition. And they're trying to find a way to deliver the work that they're doing in the evenings, at weekends, in their spare time. They have little resources and time and even less money. And they generally, at point of formation, lack the knowledge of the charity sector or know anything about life sciences. But this is normal. Despite this, they do a hugely amazing job, achieve massive amounts from simply that drive and disease understanding. And we as an organisation are here to help those groups, here to help patient groups be themselves. We're here to help you be you. We've worked with loads of patient groups over the years. In 2021, 22, we worked with over 160 different patient groups, and 45 of those were from outside the UK. We work with across a range of different training programs to help groups really find a way to move things forward, whether that's in scientific side of things, like building registries, or simply how to do fundraising. And we've managed to run events like our virtual rare disease showcase or international rare disease showcase that really bring together a diverse group of stakeholders in rare diseases, helping patient groups therefore connect with the clinicians, the researchers, the biotechs and the pharma groups they need to move things forward. And it's an impact that we're very proud of at Beacon. In all of this work, we're trying to drive patient groups forward and push them to the heart of research and heart of the development of rare care. And this is crucial, but it's important to recognise this progress that those patient groups make does create new demands. Patient groups actually can achieve a huge amount in a whole range of areas just on volunteer time alone, but their resources are limited and their knowledge is limited. And what we need to avoid moving forward in the rare disease space, as patient centricity moves from being a buzzword to a way of working, is to ensure that we don't shift huge parts of the burden of the kind of successful rare disease drug development pathway onto patients and patient groups in the charity sector, rather than actually providing them with financial support and training they need to do this effectively. And this is something that really worries me. We need to find ways to help patient groups become more professional, and that's what I'm hoping to do more at the time of Beacon. It is something that we've seen happening more in the US, and hopefully we'll see this spreading out. The Chan Zuckerberg Initiative have started a Rare as One project. Rare disease is a major focus for them. And they've created a network of US patient groups in doing this. They've been providing them with capacity building training, much like we do at Beacon. But what they've done further than that is invested for their finances to support these groups and put the finances to help those groups build their underlying structure, to professionalize with fundraising tools, with contact management systems, actually to hire professional staff members. And this has a transforming effect on what patient groups can achieve, and it's crucial. There's a wealth of work that we do at Beacon and that people at the Chan Zuckerberg Initiative and a whole range of different groups around the world do to support patient groups, finding ways to make connections between them. The breadth of the projects we're doing, though, all have a single, simple message. We want to build a united rare disease community, a community that recognises the power of working together with each other. Despite disparate diseases, there is a common experience. And I really believe that that community needs to be global, that we need to find ways to share our experiences between the UK and Singapore, Singapore and Africa, Africa and America. The more we can do that, the more we can bring rare diseases to the forefront of people's minds. We can recognise their importance as a global health imperative and actually break the isolation that rare disease patients feel. And that's absolutely crucial. I just want you guys to know that you aren't alone in your experience. There is a world of parallels out there between the patient experience all over the world. So please do reach out, connect, and share your stories widely for rare disease today. I hope you enjoy the rest of the session today. I'm really pleased to be able to speak to you by video, and I'd love to take any questions through Raj or by email. So please do reach out to me. Thank you so much.
So I think, thank you, Rick. He recorded the message last night, and Rick has Find a Cure in Beacon right now. They're working towards engaging with the community in this part of the region. I think they also reach out to Preeya soon. They do a lot of work in trying to actually involve the patient voice in, making new decisions, progress as well. I think Rick has put it down into 4 key points: isolation, equity of care, innovation in medicine, importance of patient engagement. I think today with the rest of the other experts who are going to share with us, I think we'll see a lot more of that. Next, we move on to Dr. Saumya Jamuar. he is a clinical geneticist at KKH, and he's also the head of the SingHealth Duke NUS Genomic Medicine Center. So Dr. Somia, over to you.
Thanks, Raj, and thanks to the organizer for inviting me. It's a pleasure to be amongst all of you, and thank you for tuning in on a Saturday afternoon. But I think this is something we all care about, so I'm glad to see some familiar faces, and hopefully today, I mean, I think as a background, as Raj mentioned, I'm a clinician, I'm a clinical geneticist, and I look after patients with rare diseases. So I'm going to give a perspective from a healthcare provider who look from that angle. And so I'm going to just cover on unseen and unknown. The first thing, again, I mean, it's a definition in terms of rare diseases. In Singapore, before 2017, there wasn't really a definition of rare disease. And we used to adopt a definition that was either from the US, which is a disease that affects fewer than 200,000 Americans, or in the EU, which is affecting fewer than 1 in 2,000. Given the small population size in Singapore, we take it as less than a disease that affects less than 1 in 2,000 people. So the question is, if it's so rare, why does it matter, right? And it matters because about 2 in 100 live births, so that means 2 in 100, 2% of all pregnancies are potentially affected by having a child with a rare disease, which globally comes to about 350 million people who have rare diseases. 80% of them are genetic. There are more than 7,000 known rare diseases. And what is interesting from the rare disease perspective is that there's a lot of unknown. And so there are almost about average of 3 new rare diseases that are being discovered every week over the last half a decade, right? The impact of these rare diseases is significant because 50% of rare diseases affect children. 30% of these children actually die by the age of 5 years. And that's something that Rick mentioned, because 95% of them do not have a treatment. And 1 in 3 children admitted to ICU have an underlying genetic disease. The other challenge with rare disease is the diagnostic odyssey. And that is the time it takes for a patient with rare disease to be recognized to have that rare disease. On an average, they go through 8 physicians. They're given 2 to 3 different diagnoses, and it takes about 7.6 years for them to get the correct diagnosis from the time of onset of symptoms. This graph actually is kind of the revolution that happened in rare disease, genetic diseases space. And a little known fact is that this inflection that happened here in 2006 was actually pioneered by a Singaporean who was actually a graduate student in University of Washington, Seattle. And she published the first paper which looked at a new technology called massively parallel sequencing, or next generation sequencing, that has actually changed how we manage patients with rare diseases, making new discoveries at a fraction of the cost that was in the past. So the first human genome costed about $2.7 billion, took 13 years. Today, I can do a genome for $1,000 in less than a week. So that's the scale of difference that has happened since the first genome was sequenced about 2 decades ago. And what that has led to is that, again, a dramatic increase in our understanding of new gene disease associations. And as I mentioned, 3 new diseases are being discovered every week at this point of time. So what we have done in KK is we started this program called Bridges, which was bringing research innovations for the diagnosis of genetic disease in Singapore back in 2014. We linked the patients and the clinicians within the through the KK Genetic Service, with genomic research institutes, either on the island in Singapore itself or externally. The idea was to utilize cutting-edge genomic technologies in collaboration with these genomic research institutes to directly benefit patients and improve their health outcomes. Over the past 8 years, we have recruited more than 600 families. We have diagnosed almost one in three patients who've gone through that program. And more importantly, in about a third of those patients, there's been a change in how they are managed. So the treatment was either more specific to what they need. They actually received treatment that would target their genetic diagnosis. And again, something that Rick mentioned, the innovations in medicine that are happening, we were seeing that in this 27%. We have moved it on from a research project to a clinical project. And this is done in 3 phases. The first one was called RapidSeq. This was in 2018, where a patient who was admitted to ICU underwent rapid sequencing to identify their genetic diagnosis. Traditionally, sequencing would take about 2 to 3 months for the results to come back. We were returning results in 10 days. So far, we have recruited more than 20 families. We have processed more than 20 families from the ICU, with a diagnostic yield coming to about 40%. We have now expanded it to include the non-ICU patients as well. And now we are, with the new hat that I have, which is looking at across SingHealth, we are looking at adult patients as well, who in the past had unknown, undefined genetic disorder, who have now grown up and now being followed in the adult hospitals. We are now using the same technologies to try to diagnose these individuals. I'd just like to end off what the journey of a patient looks like in our clinic. The patient comes into our clinic, and usually, because we are in KK, it's a pediatric patient, so they come with the parents. We do an assessment where we take history, but more importantly, we take a family history to understand is there any link to anyone else in the family. We have access to genetic tests, and those results come back within 4 to 12 weeks. We have a report which we return back to the patients. But because genetics is not just about the individual, it's about the family. Because we share our genes with the family, we actually try to reach out to the family members as well. There are still many processes within this simplified journey that need to be tweaked and improved. But I think the biggest challenge at this point of time that I see is still the first step, the patient referral. A lot of the patients still are not recognized to have a rare disease, and they are not referred into our clinics for that management. And this is something I think the next speaker is going to talk about as well. So maybe I'll stop here, and then we'll take questions later on.
Thank you, Dr. Saumya. Thank you very much. So I think some of the points you mentioned, I think very critical. Like 3 new rare diseases are being discovered every week, and 600 families have been recruited. So the numbers are actually pretty high. But I think what's good is the diagnostic yield that you're showing, 33%. With that, now we move to Dr. Choo-Beng from Takeda. Before he starts, I would like to also thank Takeda for supporting this effort for us to bring this whole discussion to mark Rare Disease Day to the community as well. So Dr. Go.
Thank you, Raj, for the kind introduction. Let me just quickly share my screen. Get the thing to. All right. So good afternoon to all attendees on the call, parents, carers, doctors, lay public. It's really an honor to be sponsoring this event and to commemorate Rare Disease Day 2022. This year, as part of this year's event, Takeda is really honored to present to you a new tool in order to improve diagnosis through our innovative research and development efforts and also partnerships. This is just a statement around our business as well as the requirements needed from an industry perspective. So how do we innovate in Takeda? The innovation here in Takeda really involves several therapeutic areas as well as our global footprint where we operate. We explore partnerships, not just with academia, but also through patient organizations like the Rare Disease Society of Singapore. And we hope that through this initiative, we will be able to improve the diagnosis of rare diseases as by the previous speaker.
Sort it out. I'm just going to throw a question out there because we have a question that's coming in. And maybe Dr. Somia, it's something that you can answer. Not difficult at all, but I think we have a parent who has asked, who should be the person referring our kid for the research to go through the diagnostic test?
Yeah, so that's a great question. And again, I think we work with the physician who's in charge, who's looking after that child. So if the child does have any concerns for a rare disease, then the physician can refer the patient to us. The other way is that we do have self-referrals that families can bring the patient in to see us, and then we can assess. Again, compared to when we first started, there are a lot more options available in terms of clinical tests. And what we would do is we would assess the family, assess the patient, and then advise accordingly whether we should go with a clinical test or whether we should go with a research test. So hope that clarifies.
Okay.
Thank you. So one more question, right, Dr. Somia? At this point of time, you said there's 7,000 plus, and then you found 600 families here. But I think, do you think that, we've crossed the mark? I've read so much of literature that, we've got more than 8,000 rare diseases that have been diagnosed. And, when we started off maybe about 4 years ago, they said there are 2,000 to 3,000 people that have estimated to have rare diseases in Singapore. Do you think that number has grown?
So there are two parts to the question. Whether the number, I think the diagnosis of patients with rare disease has grown. So the number of patients is there because there's 2% of every birth cohort, right?
Okay.
But what we are able to do is we are able to give a name to what that condition is. And so just to highlight that, out of the the 33% where we did diagnose, 6 of them were actually complete the first time that they were being described globally, not just in Singapore. And over the past half a decade, we've had at least 10 to 20 families where the individual is the only one in Singapore with that rare disease.
Thank you. Choo-Beng, are you comfortable?
Possible that Raj, you share your...
Sure. Simon, do you have it ready? Yeah.
By the previous speaker about the journey of diagnostics for the rare disease patient. So if you go to the next slide, I just wanted to highlight that in Takeda, apart from rare diseases, we are also involved in other therapeutic areas. And we would like to actually share the expertise and learnings from the other therapeutic areas, particularly in the field of genetics. That is a very rapidly advancing space in order to bring that and translate that into value in rare disease. And today, if you see the rare disease portfolio in Takeda, what we are particularly interested in is Fabry and Gaucher's disease. So next slide, please. So I present to you the symptom matcher, which aims to really simplify the search for information and to be able to connect the patient with the correct doctor, as alluded to from the previous presentation as well. Next slide. So from 3 sources of information here, and thank you, Dr. Somia, for introducing bridges. On average, it takes up to 5 years for this patient journey to come to a diagnostic confirmation that there could possibly be a rare disease. Now, this can be alluded to a lack of awareness amongst clinicians, and at the same time, from the diversity and non-specificity of the presenting symptoms. We also know that in the Fabry outcome survey, It's estimated to take up to 15 years in order to confirm diagnosis. And also from the Gaucher study, referenced here, 7 years to clinical diagnosis. So all in all, it takes years in order for a very anxious parent with a child who's ill in order to really come to an accurate diagnosis, in order to commence appropriate treatment for this disease. Next slide. So how do we then close this time to diagnosis gap? Let's look at it from the point of view of diagnosis, resources, as well as connectivity to local treatment centers, as well as support groups like this that we are sharing with today. It's all about disease awareness. And many of these diseases have a significant family history and a genetic link. So how do we then create that awareness in the community, and at the same time for these genetics and genetically linked histories that could be presented when these patients and parents see doctors? And then what about resources? A lot of it is shrouded in jargon and at the same time complex science involving knowledge that is usually accessible to a select medical community, but not accessible to the lay public. So with this tool that we will present to you, we hope that with this, it offers a practical and actionable resource for the lay public and also general physicians to be able to access. But more importantly, once they have access to this resource, how do they then get good referrals to local treatment centers and specialist groups, as well as support groups? Because we recognize that it's not just the clinicians, but also almost an ecosystem or a village in order to provide this lifelong support once this diagnosis is made. Next slide. So I present to you the symptom matcher for Fabry and Gaucher disease. So these are two websites that will be made available next month in March. Is it fabry.sg and is it gaucher.sg? So these are just screenshots of the landing page. And then in the next few slides, I'll take you through the portal that will enable earlier diagnosis. Next slide. So this tool, on the surface, it does look fairly basic, but actually behind it is actually a machine learning artificial intelligence support. So we've linked up with a genetic database in order to provide this very easy to use information site for the user to access disease information around the symptoms that they are concerned about. And at the same time, we will also enable contact details of these support group be made available on this website. And also the local treatment centers, such as KK Hospital, with the capability to diagnose and treat these diseases. Now, this tool is facilitated by a web-based self-administrated symptom matching questionnaire that the user will be able to complete. And this is intentionally made to be simple and easy to understand so that they can actually match the symptoms that they are concerned about with what is available on this portal. Now, the output of this tool is then to enable the user to print out a questionnaire outcome report that he or she can bring to the physician, who then would be able to refer to a specialist center or even share it with a specialist center. Next slide, please. This is just a simple infographic to illustrate how this works. Sally, a mother from Singapore, is concerned that her child could have a serious illness. So what she's done is she's seen many doctors, but she hasn't been able to obtain an accurate diagnosis. She goes onto Google and she does a search. Now, through a search engine optimizing approach, she lands on the symptom matcher tool. Now she opens this website, next slide please, that would then take her down this pathway. Next slide please. That would either be a true pathway that leads to a suspicion around Fabry disease, whereby she eventually, as mentioned, would obtain a questionnaire that she can complete and then obtain a readout in terms of a PDF that's printable that she can bring to the specialist center. If this is false, So it's unlikely that a child could have Fabry disease, but she continues to have access to information through the Think Genetics Full Symptom Matcher, which is cataloged to more than 7,000 genetic diseases. So all is not lost in terms of the information seeking process. Next slide. So these are the two outputs that I described. One is on the left-hand side, the questionnaire that is used to match the symptoms, and the PDF or the printable document that can be produced for her to bring to the specialist center for referral. Next slide. So with that, on this year's Rare Disease Day, we would like to share with you the availability of this tool next month to hopefully offer an earlier diagnosis for Fabry and Gaucher's disease. Thank you very much for your attention.
Thank you, Dr. Goh. I think there's a very big keyword that you mentioned, ecosystem. So I think what we're going to do is to move to the next expert from Thailand, but not from Singapore, so we can actually figure out how the VTL works here. We're going to ask Preeya to actually share with us the journey of rare diseases in Thailand, actually more like the continuing journey, because I think it's been a struggle. I think I met Preeya when we were working on the rare disease conference in Singapore. I think 2014, I met her in 2016. Singapore moved into the impact study in 2017. I believe Preeya worked on the impact in Thailand as well with a group, and I think something was established maybe in 2019 or 2020. So Preeya, if you can share with us what's been done in Thailand, how you've arrived, and the challenges that you still continue to face.
Thank you, Raj. Just allow me to share my screen. Thank you once again, Raj, for having me on this panel. I am much honored. Before we get into the journey we have here in Thailand, I just wanted to give a brief introduction to myself, as you saw on the slide. So I'm essentially now a patient caretaker. So it's been 8+ years now on this journey. Learned a lot and been part of a very commendable group here in Thailand to drive the rare disease journey. And just a small segment here to share with you how we've managed to come where we are now. Sorry. Can you see the slide?
Yeah, we can see.
But I'm not able to go forward in my slide. Okay, there we are. Oh, no. Sorry, give me a sec.
You all right, Preeya?
Yeah, I'm all right. I'm not sure why I'm not able to continue with the slide.
So maybe what we do, we take another question now. So I think this question can go to both Dr. Goh as well as Dr. Somia. I think it's from someone who's anonymous. What are some of the biggest gaps to access rare disease diagnostics in Singapore? Is cost ever an issue? Dr. Goh, would you like to take that? Yeah.
So I would say the biggest challenge for diagnosis of rare disease in Singapore is really awareness and education community. Often enough, I think not enough is being made in the lay public space to be aware that actually these rare diseases do exist. And often there is a confusion around what really constitutes like a Fabry disease with some commonly perceived handicaps in the community, as you mentioned, like autism or even children with special needs. So there is still a very large need, I have to say, in this space in order to educate people. And efforts will be made, definitely, and it is events like this that we continue to reach out to the community.
Thank you. Dr. Somia, any thoughts on this?
Yeah, no, I agree. I mean, I think awareness is one of the key aspects. I just wanted to add that, that's something that we've been working on our side as well. Again, organizing medical education talks and talking to GPs, pediatricians about rare diseases. I think the bigger challenge from that awareness perspective is that, traditionally rare diseases were meant to be affecting children. And so the awareness was focused primarily for the pediatricians. But now we are realizing that actually rare diseases affect adults as well. And that's something that within SingHealth in 2019, we set up the SingHealth Duke NUS Genomic Medicine Center. And now we've got a genetics clinic that's running in most of the SingHealth institutes, including SGH, Heart Center, SNEC, Sengkang, and one coming up in Changi sometime this year. So we are slowly increasing the awareness. The next is the infrastructure and the capacity. Again, there are not that many of us who are looking at rare diseases. So again, that's something that's being looked into. And then the last is access to technology, whether it's within Singapore or externally, and then cost then becomes an issue.
Right. Thank you. I think now there is another question which asked, can you comment on the 20% of other rare diseases without a genetic basis? What are the resources to diagnose and treat these patients?
Yeah. So that's a great question. And again, when we talk about rare diseases, these are diseases that affect very few people. And while we know that majority of them are genetic, there are that 20% where we don't find a genetic cause. And this is where the environmental impact comes in. And so I think a couple of years ago, I think many of us are familiar with the Zika outbreak that happened, that led to babies being born with very small head or microcephaly. So infections during the pregnancy, exposure to certain medications that are harmful to the baby. And again, in Singapore, again, the way it's regulated, and the way this infrastructure is, we don't see that very often, but that used to be one of the common causes in the past in the West, globally, where we would see children being born because the mom was exposed to certain medication or even toxins, things like drugs and other things. So those are the 20%. And again, there is that unknown where we don't fully understand, and that's because we don't understand human biology, the genome completely. There are 20,000 genes. We only understand about 8,000 of them. So there are 12,000 genes that we don't know about. So many reasons for that 20%. Yeah.
Thank you very much. Yeah, thank you very much. Preeya, are you ready?
Yeah.
Okay, wonderful.
Okay, sorry about that glitch. Before I get into the journey, I'd like just to share that the Thyroid Disease Foundation is at the moment on its 6th year, and the last 5 years have proven that giving a strong support to patients' voices can transform a lot of things. And the Rare Disease Foundation has brought together members from different walks of life and capabilities, but we all share the same goal. Our kids might have different diseases, but the problems that we discovered are all similar. And having come together with the same goal, it has truly catapulted the rare disease journey here. Thai RDF was set up in September 2016. And we spent the first 2 years mainly building patients' voices, bringing together different patient groups, working with different doctors in the different hospitals, and spreading public awareness on the rare disease journey here in Thailand. And in 2019 is when we saw a breakthrough. So the NHSO here and other relevant government agencies that are responsible for the universal health care decided to put together a rare disease committee, which comprised of about 30 different people, including pharma, including government agencies for medicine approval, doctors, patient groups. So there was a wide variety of people who got involved and had to answer several key questions, such as the first one being, how do you define rare disease here in Thailand? Because without that, you don't know how to segment the rest of the journey. So once we got through that and defined rare disease clearly, then we got down to figuring out about what do we start with. We look at rare disease, it looks like an elephant. It's a big mammoth to walk if you take the whole chunk of 7,000 diseases in one shot. It seems overwhelming. So we broke it down into 3 different parts. One is what we call quick win, what you can quickly solve and cost less and has a maybe an easier way to understand, has clear diagnostics. Second is the next level of diseases where there are medicines for them, but perhaps the medicine not yet in Thailand, not approved, and it might take a little longer to diagnose, but there is a clear path to recovery. And the third set of diseases is where there's perhaps no cure, it requires palliative care. Having broken down that, we managed to come in October 2019 with the decision to approve 24 rare diseases, with a choice of those being the ones that are inborn error of metabolism. Why were these chosen? Because it fit with the criteria that they were easily understood compared to many other diseases that we have. It was less costly, and the cost of care was lower if you could diagnose them quick. And the medicines that needed to take care was also available. It just needed to be pushed through the orphan drug pipeline quicker. So that was what we saw as the groundbreaking or the breakthrough of a broad coverage of 24 diseases put into the universal healthcare. Then in 2020, we looked at how to build further onto that success. And that's when COVID hit quite heavily, and obviously things got delayed. But we were able to get started on building a data registry because all key stakeholders, one thing was clear, that without data, you can't have the right acknowledgement or understanding on how to approach the next step. So with the right data on patients, on patient support, on the cost, we're able to make clear decisions. And this required bringing together and deciding on what hospitals were going to come in this data collection and who was going to own this data, who's going to fund this data collection process. So we have chosen 7 tertiary hospitals, 6 of them here in Bangkok, and 1 is in Northeast. And these hospitals, all the doctors work together. They meet every month. They work together. And right now they're working towards the IT that's behind in order to create the data registry. But the most important question comes down to who will eventually take care of this registry once it's developed. How to update this as we have the data in hand eventually. In 2021, we had a very interesting Rare Disease Day, which we held. It was a multi-stakeholder engagement, and it addressed the 3 parameters of rare disease policy that we're looking at. One being access to medicine, second is the data registry discussion, and third being alternative financing. And this really gave us a lot of information to work with, which I will share with you what we found. So in 2021, when we had the Rare Disease Day, we discussed and furthered the information on first point being data registry. So as I mentioned, we had chosen 7 hospitals, and how to execute that plan and who takes charge in each hospital, that's in the pipeline of discussion now. The IT system has been decided. We know what we want to collect. We know how we want to structure it, which company will work on it. But right now it's being overseen as to funding, as to ownership. And the green light was given on 8th of April 2021 to fund this system. And now we're in the final processes of executing it. The next thing that we discussed was about alternative financing, which is perhaps one of the most, what I would call fluffy or harder parameters to pin down. So where do we get the money from? Who's going to finance the rare disease journey in a sustainable way? And recently in June 2021, the Rare Disease Working Committee and 2 other government agencies met with 3 to 4 pharmaceutical companies in a closed door meeting, requesting them to present an MEA, from their side to share what their thoughts were on building a sustainable future funding for rare diseases that have a high cost. So that's, I think, I would say still high level discussion. But that's the MEA route is what they're discussing about in terms of financing, because right now there's a budget that's come out from the government, but it's a small budget, and that budget is not able to cover the diseases that have high cost. So how do we take the next step in getting those diseases into the universal healthcare is a journey that we're going through this year. The next one was about access to medicine. So this one went through a lot of discussion. We had some good wins, such as the medicine for LSD, for MPS and Pompe, passed through the Rare Disease Working Committee for Medicines at the end of 2020, and right now is currently in the final process of approval. So this gives us 2 more medicines that will allow approval through the universal healthcare. And we are seeing that the Rare Disease Working Committee for Medicines has created an expedited process, a clear one, that allows for orphan drugs to be listed in the master medicine list of universal healthcare. And right now, they're targeting about 3 medicines by the end of this year. In addition, because 24 rare diseases that were approved are part of the inborn errors of metabolism, which many of them require different metabolic powder milk, in order to provide quality of life for the children who have the disease. That's been gone through like an expedited process of approval to get a license to be sold, through hospitals. So that's the next, let's just say, good win we've had. And the third one that we're looking at is approval for 2 medicines, which is the BH4 and the nitisinone. That's at the moment not registered for use here, but is crucial for the care of the 24 diseases that have been approved. So approvals have been received, medicines have been purchased, and now is in the final process of registration for legal hospital use. So getting the medicine journey, but this again, if you look at it from an outside perspective, it's still again piecemeal. We're still not able to obviously provide a blanket coverage on medicines that are required. We're still having to go in with a paper, with a report to show what medicines we need, why we need, and it's approved paper by paper, which does require a lot of effort and work on the back end of the doctors, of patient groups, of even the patients themselves to share data, information, and to do that for every medicine is going to be very time consuming, and not everyone has so much time to do this medicine by medicine. So we're looking at how do we do this, maybe segment by segment. So this is just to summarize, in a way what the journey looks like today. So while we have a much better landscape of rare disease here in Thailand compared to when I first had my son 8.5 years ago, there's still a lot that we can do. There are still medicines that we don't have for use and necessary treatments for other rare diseases that are very much required but not yet approved. But because they're expensive, the idea of cost effectiveness, how do we deal with that, the economics of it is something we still have to work through that. And we've had the stakeholder meetings, we've had multi-stakeholder workshops, a lot of information on hand, but to translate that into execution, into plans, is what our journey now looks like. So when it comes to challenges, we have seen many, and to what end and what conclusions, that's going to be something that we hope to see in a more clearer picture going forward. What does the journey look like going in the next maybe 1, 2, 3 years ahead? So in a quick summary, Thai population, for 5% of our population have one of the rare diseases. That makes 3 million out of the number of people that we have now. And at present, only about 20,000 of them receive treatment currently, which means 6,000 rare diseases still don't have access to treatment. we know in Thailand right now, we know for a fact 300 diseases that exist in patients that we are already taking care of, out of which at the moment only 24 are covered. That's a lot of diseases that we still need to get into the universal healthcare for coverage. So there are challenges, but we remain hopeful. Tomorrow, Thailand also celebrates the rare disease event, as you are doing today here in Singapore. And it marks a very important moment because Thailand rare disease began its journey actually 12 years ago in 2010. In its infancy, when it began newly, there was almost no support. You can't even call it funding, like zero funding, and very little market response to the day or to the movement. Only a very small circle of people knew about rare disease, and the same story was repeated year in and year out to try to get traction and get people to understand what rare disease even was. Looking today, in 2016, we created Thai RDF, and then fast forward today, about 5-6 years later, there's a whole different landscape. We were just discussing with our team yesterday, many of us in tears, not knowing how we got here. Because while the challenges are evident, we have a lot more hope today. If you look at just the event banner of tomorrow, so it's the size a bit small. If I look back when we began even this in 2016, we might have had 2 partners up there and maybe 2 sponsors officially. Today the banner is full. We had to make everyone's logo a bit smaller so everyone's logo could fit. That means something. It means that there's a lot of partners who want to be in the game, who have invested time, invested money, invested effort to take this journey forward. And that in itself speaks volumes for how much more we can do here in Thailand. So with that, I hope to come back to you again in the future with more to share. Thank you for your time, and thank you for having me.
Thank you, Preeya. It's always good to hear, right, that we worked on this for such a long time and see Thailand's made such good progress. Some of the keywords: rare disease is overwhelming, data is key, alternative funding to move forward, access to medication still remains, partners to take this forward. I think what you're doing is positioning our discussion very well. That's where we are heading as well. So I think what we're going to do is we're going to ask, we're going to move to Sing now. I think this is the critical part of our content, the caregiver's perspective. I think this is key to many decision-making processes. For our process, how do we take it forward? So I think we're going to have Sing share from his perspective, and I'm glad that he's going to share with us something that's so in-depth about what's next for us. These are thoughts of the caregiver. Sing? Yeah.
Thank you, Raj. Thank you, everyone. I'm Sing. Just let me share my screen.
I really hope no one's bombing anybody now. Yeah.
All right.
Oops. You all right, Sing? Somewhere you got it on standby. You got Sing, but nothing's coming out as yet. Okay, great, wonderful.
Screen, no?
Yeah, good.
Okay. I thought since I'm supposed to talk about what's next from a caregiver perspective, it'll be good for me to do a little bit of an introduction of the family nucleus as well as my caregiving journey. So this my boy Wen Jie. He has got X-linked adrenal dystrophy. It's a mouthful, but it's X-ALD in short. Okay, so this is not a new disease. It has been discovered quite some time ago, but it's very small numbers in Singapore's even in a rare disease context. Okay, so this is us. Wen Jie has got 2 other siblings. The elder sister Wen Sing, the younger brother Wen Zhe. They both enjoys playing the Chinese music and the younger boy also loves football, which Wen Jie, before he fell sick, also loves football. So one of the activity we usually does with him is to bring him out for his morning walks to get his vitamin Ds and also get connected with his surroundings. Okay. And you can see the sister is also able to feed him via the NG tube. And because of his sunny disposition and character and stuff, we are fortunate that we are involved in, you know, some of the A Good Day project from HCA, as well as we have the opportunity to meet up with President Halimah. Okay, so how Wen Jie actually was born normal. So at birth, in fact, if you look at him, 10 months, he could already form words, assisted walking. 14, 18 months, he could actually gain independence, and you know, he was actually doing very well in his studies, preschool studies.
Neutral.
That's him trying to give a rendition of a Chinese, you know, show and tell. But now he's actually, you know, on a wheelchair and also needing a feeding tube. Okay, so this is just about before he was diagnosed, in somewhere in July 2014. And in the space of 2 months, very quickly we see a downward spin in terms of his development. And that period was really a struggle for us because we have to run from various clinics as well as from hospital to hospital to try to get a diagnosis of him. And within a space of 2 months of diagnosis, we have decided to actually go through bone marrow transplant, the chemotherapy, as well as doing a stem cell transplant with him, harvesting from me. So within a space of 2 months where he was staying in a high dependency ward, he came out having to be, you know, tube fed and bedridden and stuff. Okay. So it was very challenging. So in what I call the 3 different stages, the early stage, we had to really learn new skills like doing suction, doing feeding tube before we can actually discharge from the hospital. And because, you know, rarely when you talk about BMT, rarely you see children actually come out being able to walk, and then coming out, you have to be totally dependent. So to discharge, we have to also prepare a list of equipment to discharge. We have to work around a feeding schedule because in hospital, you could have nurses coming to help with all the feedings in terms of medication as well as milk. But coming home, we had to understand how can we have this cycle so that the caregiver can actually still cope within the feeding schedule. And we have to have some sort of operating manual at home so that the different caregivers at home could actually know what kind of stage he is going through the day already, and to really also prepare not just you know, the parents, but the siblings and the extended family to deal with the kind of condition and the state that he is. Okay. And then when we discharge, we are very fortunate that we have actually palliative care support. So that was really helpful because it's patient-centric, it was family-centric. We find that there's holistic support. We realized that there were episodes of him having fevers, and realized that actually there was a possibility of some reflux in him. And so we have to go and look into his dieting plan, from a purely milk feed to a mixture of milk as well as you know, purees in between the feeds. There were any medical consultations were actually easy because we could just dial a number and the team will actually come to home. As well as then we have the opportunity to explore therapies to actually help him improve and retain his abilities, like for instance, speech, as well as physiotherapy and stuff. So probably about 2-3 years ago, he was deemed stable enough to be discharged from palliative care. So we are on our own at the moment, and we find that over the years, over that space of 3 years, there are some challenges that come on board. Firstly, we realized that being bedridden for a while, there was sign that he was of slow declining health, meaning that his swallowing, his muscle was weaker. The swallowing has got is a little bit more impaired compared to perhaps 7 years ago. And then there was his physical growth that we had to deal with, and as he grew slightly taller, his leg being if you can see here, being bended inwards. Actually, we are worried about possibly skin tear and then wound care because of the growth, and perhaps if when puberty hits, then the growth spurt will actually cause more problems for us to take care of him. And then of course, I think we are given that we have so many things to do, engaging him meaningfully is also an area that we are very looking out for, but didn't really have the time and space to explore. And then with COVID, it doesn't really help, if we have to be very careful with him so that we do a lot of preventive care, because if he were to ward into a hospital, there will always be challenges that the COVID measures would present. Caregiving help. Currently, we are fortunate to have a long-time helper with us, but moving forward, we do not know how it will pan out. Okay, financially, like if you see the table below, and as well as the one that he's wearing, the AFO casting that we just did for him, just this AFO casting itself will cost us in the range of about $800 to $900, just because of his growth, that we had to keep his leg to be casted so that it doesn't get worse. It's a preventive measure. And then medications, just taking snapshots of when he was discharged, and the medication itself, not taking into consideration the dosage increase over time because of his weight and growth. Some, if you are looking at Fudro and hydrocortisone, which his condition would require, like because he has got a adrenal deficiency, you're talking about 1.5 to 2-folds of the cost that we are paying for medication. So rising cost of medication is also our concern. So coming to that, I think that's why we are very fortunate that we join RDSS, so that as a community we find parent support within the community, and from there understand that actually we did an impact study about 5 years ago, and recently I think we did try to do a stocktake survey to do a stocktake of where we are, but from early info that we glean, actually from a caregiver perspective, the needs haven't really changed much. Things like we are talking about early intervention, access to genetic testing, access to clinical trials of orphan drugs. This aren't something new. It's still there. Even global studies like the NOTS Rare Disease 30 Years Survey conclude the same kind of needs from the caregiver perspective. But what we have not really seen or feel is that the solution to this have not come about fast enough to impact the life of rare disease children, our patients, as well as caregivers. So we I really think that it's a really multi-stakeholders kind of environment. You know, we have the government, the hospitals, the schools. Yeah, I'm not talking about just medical schools so that the younger doctors knows it, but in awareness as well as young children who will be our next generation to actually know us. You know, does the primary school or the youth actually know that there are rare disease patients and caregivers actually living among us? We have to talk to insurance companies, for instance, because some changes could affect us very much when the hospital bill is actually huge. Communities, not just local communities. I think as rare diseases also, you know, we have many communities, but also communities overseas, because I think there's much to learn and exchange, as well as those things that we are looking for, like clinical trials and orphan drugs. Very often they are not actually started or developed in Singapore. So we have to plug in to know this information, this knowledge, so that we know how to assess it. And so really we are looking for future Singapore where we have a more inclusive society, where we have a rare community ecosystem. So with that, I thank you.
Thank you very much, Wee Seng. I think it's very clear. I think there's one term that keeps repeating itself in this whole discussion, is the ecosystem. I think it's come from Dr. Goh from Takeda, it's come from Preeya, also Wee Seng. Also, I think Wee Seng, some of his key points were home care challenges, the ecosystem that we must build, the expensive medication, the planning for future, support for caregivers, and the lacking of information. I think what we'll do is we'll go into a panel discussion after we take a 5 minutes break. It is now close to 3:50. Maybe what we'll do is we'll come back at 3:55 and go directly into the panel discussion, starting with Kenneth, who will present plans for the Rare Disorder Society of Singapore, and then we will take the discussion forward from that. So I think let's take a break for 5 minutes, and let's be back on time at 3:55 for us to continue the discussion. Thank you. All right, we should start in a couple of seconds. We're just waiting for Preeya to join us as well. Great. So Preeya, just on time, on the dot. Now I think let's start with Kenneth Ma, Vice President of Rare Disorder Society of Singapore. It's been 11 years since his journey, since 2011. Right now it's going 11. And let's see what the society has for, Singapore rare disease families. Where can we go? What is it that we need to do? And what are the needs at this point of time? I think we had a session with the families internally on the 21st of January. They have raised a couple of points, I think not very different from what Seng has brought up. So Kenneth, over to you for RDSS take here.
Okay, thank you, Raj, and thank you everyone for spending the great afternoon with us. Okay, moving forward, for us, actually, to start with, I would like to share that though my child's condition is different from Seng's boy, but the kind of caregiving journey, the kind of challenges that I'm going through is actually exactly like what Seng is going through. In fact, my next challenge will be what's going to happen when my child reach 18 years old. So what's the life beyond 18? So this is something that is something that we need to look into. So years back, I mean, we didn't really focus in this when we first launched our rare disease impact study. So over at RDSS, we will hopefully coming within this year or by 2023, we are going to launch a rare disease impact study 2. Okay, we have a version 1 now, we are moving towards a version 2. So we are going to see after 5 years, what kind of changes were there in Singapore. Yeah, so I'll be working very closely with Raj again to have this rare impact study to be presented again. And then hopefully from there, we have the data, we have the feedback, and then we can actually move towards a greater plan, a bigger plan, which is the rare disease master enabling plan, which are both myself and Seng and the team in RDSS is working on. And then over here, I mean, one thing that we cannot stop is the advocacy for rare. Okay, yeah, so we will always and we will continue to highlight the challenges of our needs, especially the family needs, the patient's needs. And there are also, some rare disease patients are actually also been diagnosed with common conditions like ADHD. They might even have autism spectrums, or West syndrome kid might also be cross-diagnosed with CP, which is relatively common in Singapore. So over here, RDSS is also trying to partner and to form a alliance with those support groups that is taking care of other special needs in Singapore. So we may be niche, but overall, I think if we speak together, we won't be neglected. There's always gap, but we have to work very hard to fill up the gap ourselves, right? So taking care of the child's basic needs, the family needs, and also the education. So over here, special needs education ends at 18. So we are also looking forward to, to see if there's a possibility that, even the child can, further receive education until the age of 21 or even longer. And then there's a lack of day activity center for people living with rare conditions, meaning to say after 18 there's nowhere to go, and this is also affecting like what you have saw before, that caregivers couldn't have a proper income because we have to take care of our kids. So if there is a proper day activity center for our children, then there is a possibility that we can go back to the workforce. Yeah. And then although Singapore has this rare disease fund, but it's actually mainly for patients that require ultra expensive treatments. But then I'm sure out of all the conditions, I mean, out of the 7,000, I mean, how many? I mean, it's only a handful that comes with expensive treatments. But how about those that require symptomatic treatments or without treatments? What will happen to those families? Because there is still a basic needs for the kids, for the families. Yeah. So over in RDSS, we are going to expand and continue to support the family with our home-based learning and therapy scheme, with our, we will organize more parent network sessions and to trying our very best to empower the parents, yeah, and to walk this journey. And then recently, one of the hot topic is about emotional well-being. Yeah, because of the kind of the stress that we are going through. I mean, I can be smiling every day and keep my momentum, keep my spirit high, but then there will still be time where, I need support, especially the emotional part. Yeah, because we can never know what will happen to our child tomorrow, or what will happen to us. So there's always this next question that many caregivers will ask ourselves is that, what will happen to my child when I'm no longer here? What's there for them? Yeah. So together, I think we want to build a very inclusive society, a community that accept our children, and also involving the stakeholders, patient engagement with us. All these things have to be in place. And I do hope that we really don't leave anyone behind. Yeah. So there are many. I would say we are just in a so-called the beginning of the journey. Though we have rare disease fund, we have many supporters, especially for this year fundraising. We have this Carry Hope fundraiser, where we receive a lot of support, and even ministers shouting out for us and becoming our ambassador. But it's just the beginning, and we hope that together we can actually get the public to give us a better support, and that will enable or allow RDSS to expand our services. And then moving forward, we even have explore about helping families with the diagnostic test. Yeah, because diagnostic tests can be expensive, right? So some family may choose not to do at all, yeah, because of the cost. So we are also looking into whether there's a possibility that the society, the charity RDSS can help family like this kind family where the physician or has actually sound out to them that there is a possibility that there is some so-called genetic condition or rare condition where they need to do a sequencing or some tests. Yeah. So these are the things that moving forward for RDSS, and I think for the rare disease community in Singapore, what we can come together to do. Thank you.
Thank you very much, Kenneth. So I'm just going to back up a little bit on what you said. So you captured many points that actually came through Rick. So I think Rick's points were equity of care isolation, importance of patient engagement, and progress creates new demands. So I think that's a very key point to note. Dr. Somia actually covered, how many rare diseases are being discovered every week, and the numbers that are in Singapore. I think one of the biggest keyword from Dr. Goh was diagnosis through innovation, and also ecosystem was his main keyword that I picked up. The next, of course, we came to Preeya, and like we saying, she pointed out rare disease is overwhelming, data is key. So I see that similarity in your content as well. She talks about alternative funding, access to medication, partners to make this journey forward. And, you know, she showed us that poster. I think it's been 11 years of rare disease now, 11 years running. I think that's how long we've worked on rare diseases. So I think the next step is actually very important for Singapore. Singapore has established a rare disease fund. I think that is a really huge step. I think Singapore, Thailand, they've taken a huge step in the region to actually move something for the patients. But I think, like you said, this whole continuum of care is not just about the patient, it's about the caregiver. It's not about just access to medication. While it is a priority, there are so many other factors to look out for. And, you know, like Seng mentioned very clearly, things are expensive. There are home care challenges for the child. The early intervention, planning for the future, access to affordable medicines, support for caregivers, information. So I don't even think Seng was talking about the ultra rare cost, but he was talking about, just like you mentioned, the other rare disease conditions. And within rare diseases, we've got rare diseases with the therapy, we've got rare diseases without a therapy, and the undiagnosed conditions. So from your perspective, I mean, all of you, I'm just going to throw a question here, but I think pointing to Kenneth first, what do you think will be the next step for Singapore? Because for me, what I've noticed in the region, and I think that's what Preeya is going towards as well in our recent conversation, we cannot let the engine idle too much. We need to figure out what is the next step, because we are the main stakeholders of this whole decision-making process. And I think things have improved a lot for Singapore. You know, people are listening in, like you mentioned, the minister is involved. I think even in the approach with the Rare Disease Fund, it was so positive, people listened. But I think what was done was to establish a framework for funding. But I think the dimension is much larger. So maybe Kenneth, Seng, you know, do you want to share what you think is the next step? What can we do?
Okay, maybe I can start first. I hope that we really can come up with a care plan for people living with rare conditions or rare disorders in Singapore. So yes, we have you know, now we have this RDF to support with the expensive treatment costs or this, but then we have to look into what's beyond, what's next, because with proper care, with proper treatments, the life of the patient will you know, the quality of life improve, as well as they live longer, to be honest, right? They were supposed to live a better life. So with this kind of treatments given to them, then what's next for them and the family? Because other than the so-called expensive treatment costs, there are also other costs involved. You know, those you know, consumable costs. I'll put it consumables. Like for example, Seng child, maybe on milk, formula milk, or those with inborn error of metabolism, they need expensive special milk formula, which is a lifelong thing. It's not about a cost. Like someone with cancer, you go for 2 years of a course of chemo or radiotherapy, you are discharged. But look at our kids. They have no chance to discharge because the condition is lifelong. Yeah. So their needs is also lifelong. So we need to we need to sit together to be engaged together and to talk about a plan, what's next. So a multi-stakeholder discussion is needed, because like for my kids, as she grow older, she grow bigger. When she grow bigger, the dosage of the treatments or the medication that she needs will increase. That means to say the cost also increase. And then judging from Singapore, our population is so small. So how many patients can we find with these conditions? So even like the pharma should come together, or even our country, like we can maybe talk about a ASEAN purchase. All the ASEAN countries come together. Then together they can actually engage with the pharma company to negotiate with a ASEAN price. Yeah, if not, you see, I can give a good example. Is my child's medication is 40% cheaper if I purchased across our causeway, our neighbor, the patient there are getting 40% lower. Why is it so? Yeah, so can we come to a possibility where when there is some ASEAN summit, maybe a rare disease can be brought up and discussed about how to have a care plan, coming together a kind of a regional discussion, and then we can start from within inside, and then from there we expand, and then we share, various countries sharing about their care plan, their work in their country, and then we can try to pick up every piece, just like zigzag puzzle, we can fix everything together and then come up with a regional plan. I think that will be something very, I would say, the caregivers like me is looking forward to. Yeah, thank you.
Thank you, Kenneth. So I think some points, like you mentioned, inclusiveness in the society, and right now I realize that due to COVID in the last 2 years, I think the work for rare diseases has kind of stalled, or maybe stagnated, because we couldn't meet in person. We didn't have those robust discussions, and of course there are new needs right now. And so I think the key points here suggest something collective, collective consensus. Preeya's point on data is also key, and you mentioned the impact tool. I'm just going to ask Dr. Goh, what do you think the various stakeholders will need to do to progress the needs of rare disease community, and who do you think these stakeholders are? Because I think we've spoken here, Preeya has mentioned, we've got industry partners, so has Kenneth, and we've mentioned so many other points. So I'm not just zooming into industry, but I think in the last impact study, I think what was clear is we had multiple partners. We even intended to engage with Rainbow Center, AWWA, StarFels, MDAS, so that it is holistic, and this is how we plan to actually deal with rare diseases. So, Dr. Goh.
Yeah, thanks, Raj, for the question. So I would like to provide a perspective, perhaps from an industry point of view, partly because not just from the provision of medications, but really, and I would like to reuse the word ecosystem again, because the pharma industry works in a very large ecosystem. And to Kenneth's point, it's actually a global ecosystem. So we actually are present in many global meetings where topics that you brought up are discussed. So at a recent APADO meeting a couple of months back, I heard many of these topics raised by rare disease groups from other countries as well. So I think as a partner for this event, the industry can actually serve to raise this to these meetings. We do have a sizable presence because we are participants in these meetings. We do have policy and access teams who work with these partners, and we can definitely raise these questions, because nothing beats the reality of what you're sharing in this forum today. Many of these meetings, often enough, it becomes a very abstract discussion because it's all about data, about numbers, statements, rhetoric, you could say. But when we actually bring your experiences and these challenges that you face to these forums, it makes the meeting so much more engaging. So that's a stakeholder village that I could say that I can share from a pharma perspective. But let's look at the patient journey. Yeah? So this year's meeting, we shared the diagnostic tool that we shared earlier. I think there is a lot that still needs to be done in the space of disease awareness and how to expedite diagnosis. So hopefully when we launch this Fabry Gaucher tool next month, we can explore the usage in other diseases as well. So this would be able to extend the awareness across the whole spectrum. We know there are many diseases. In fact, as Raj said, right, we shouldn't let the engine idle. I think this engine shouldn't idle for the next few decades because there's just so much work to be done. honestly speaking, I think the symptom matcher is a start, and we are definitely internally looking at other diseases as well. In the pipeline that we have for Takeda, we have many more rare genetic diseases. In fact, there is one that involves pediatric epilepsy, very uncontrollable pediatric epilepsy. These children have recalcitrant epileptic episodes. And we hope that in that space, we can also be able to offer early diagnosis as well as holistic care.
Thank you, Dr. Goh. So, Wee Sing, I come back to you on the same question because you actually did sound out a little bit of a plan to actually move forward. Yeah.
I think to me, what I see is that I think in Singapore, our advocacy and education work have to step up. The reason being, I think on an economic front, those issues and challenges on the economic front that is really specific to the rare disease community. Like for instance, you know, the expensive medications and so on and so forth. I don't think we are going to get a very, because it goes into economics, it's very difficult to have a direct answer. And so, like what I think Dr. Rick have mentioned, the best is I think for the support group, the advocacy group to actually look for industry partners, partners who are willing to participate, like for instance, the pharma companies, the hospital, the physician, to explore what could be a model and make a certain recommendation. But that aside, I think there are still another aspect which is more in terms of accessibility within the society itself. What I meant was points like we have to really look at the patient's journey, like we have conversation before, Raj. And Kenneth pointed out things like daycare center, whether there could be childcare center, but could there be an equivalent or expand that scope to also cover the rare disease community? So what I think there is just a delta cost. So it's not purely building one that is specifically for the rare diseases, but to put our requirements in so that they know that our requirements is slightly different, see whether we could incorporate into their plans. So that's how I see these two moving in together as we try to expedite the kind of solution that we can bring about in the Singapore context and to impact really the caregivers and patients.
Thank you very much. Dr. Somia, what do you think of this? I mean, we've heard repeatedly in a couple of recent interviews that I had with even the oncologists, I think they mentioned very clearly that what's key is we must get the patients to move it. And, you know, even in that space, what are your thoughts on this? And, you know, how do you think things can improve holistically? Yeah, not in any one particular area, but, you know.
Yeah, I mean, I think what I wish for is I had a magic wand, right? And we could kind of solve, but unfortunately, I think we all have our constraints. And I think this is where something that Kenneth talked about, multiple stakeholder engagement, is key. And to me, the multiple stakeholders starts with the patients and the families, because they're the most invested in this. That's their individual. But it's not just about them, but it's about building that community. And again, you know, the last 8 years have been great because of social media in a way, because social media goes beyond Singapore. It connects families to individuals globally. And that to me has been a big positive of Facebook, right? In terms of getting that support that doesn't exist. Learning from them, understanding how they have tackled those challenges in their geographies, in their countries, with their regulators, and then trying to use some of those tricks and techniques, right? The second aspect is the healthcare professionals themselves. And again, you know, we have been, I mean, what we are working towards is helping facilitate that diagnostic journey. Because I think one of the biggest challenges with rare diseases is the awareness and people not recognizing it, and if there is a way to improve that process, right, making technology accessible to people, giving those results as soon as we can, right? All those things come in. There is the regulatory and the government aspect of it, which again, I think there's a lot of movement over the last few years. And then the pharma, engaging them in terms of figuring out the cost of the treatment. Again, I want to take a step back and say, when I, as a physician, when I see a patient with a rare disease, in my mind, I look at it I'm trying to solve two problems. The first problem is, what does this patient have? And that's a diagnostic conundrum, right? What does this patient have? And the second is, how can I solve this patient's problem, right? Which is the management problem, right? They can run in parallel. They don't have to run in sequence, right? And in the past, we used to manage patients without knowing what they had. Now with technology, yes, some of them are still very costly, but we are able to diagnose more and more of them. But that doesn't take away the fact that we can still manage them. Within management, there are two aspects of it. The first aspect is the specific treatment for that rare disease. So if the patient has Pompe disease, they need an enzyme replacement therapy, which is very expensive. But then there is a common theme of the generic, not specifically for that disease, which is the rest of it, right? The caregiver training for feeding, the AFOs, the physiotherapy and all that. And I think breaking it down into different pieces allows us to say, okay, we can't solve all the problems, but let's solve these problems which are low hanging, and then slowly go up and solve the bigger problem. But I think it has to be a multi-stakeholder engagement to move things forward. And again, I mean, I must say that, things have progressed in the last decade in all fronts, right? I mean, the RDSS, the RDF, pharma engagement, the symptom matcher, all these are steps towards them. Again, it's a journey. And as Choo-Beng says, it's going to be something that the engine needs to keep running for the next 20 years, because it is going to take some time. But I think we are moving in that direction. And that to me is a big positive.
Yeah, thank you, Dr. Somia. So actually, we're going back to Rick's point. Progress creates new demands. So right now we have new demands for new data, a new reason for us to think about the next step for rare diseases. I want to come to Preeya from a third-party perspective. So you heard so much about Singapore right now. So you tell us what your thoughts are, and whether we're heading in the right direction. You think it's something that we can do, but don't do our job.
I think it's really great to hear different perspectives, both from a physician perspective, from a caregiver perspective of Singapore. And as a caregiver myself, we share a lot of parallel, issues, and the journey's been similar in many, many aspects. In the case of those of us who are sitting here in the Rare Disease Committee, most of us here are caregivers ourselves to children with different diseases. And I think one factor that I really would like to learn, or perhaps adopt from Singapore, if that's even possible, is how to make the journey here more holistic. Here in Thailand, how do we provide, as a caregiver myself, we have not been able as caregivers to get any kind of actual support. The support we are getting right now is for our children. What we're doing is for our kids. We're running for them, doing for them. But you burn out. As a caregiver, you burn out. So there's only so much you can do without having to take a break and then come back. But there's no actual system that takes care of that burnout for the caregivers here in Thailand. And so we've discussed about this here. And there's so many aspects you have to look at in terms of where do our kids go to school. Just today, actually I had a call in the morning trying to find a school for my son. Thailand has 95 international private schools. Only 2 are inclusive. We have a long way to make the life here for rare disease more inclusive, to allow more options What work can they do tomorrow? What do we give caregivers? Where will our kids go to study in a more inclusive way, so they're not, cast aside by society. So in addition to all the medicine we're trying to chase and all the pathways to make rare disease, even the main area work, there's a lot of background that needs work as well. And that holistic is going to take us years to get there. So the journey is a long, long journey for us here.
Yeah, thank you, Preeya. I think we can continue the conversation tomorrow. So we'll ask the same question tomorrow when Thailand hosts the Rare Disease Day. So I think, what's quite clear is Preeya has also mentioned the same thing, and I keep hearing, I think what we need to do is to figure out what is the new needs of our patients. And, from a qualitative perspective, what do they want to? And not just looking at ultra rare, but we're looking at the whole community and see how we can develop something that's collaborative. And I think Preeya's point is so valid, right? That we need to also think about the caregiver, the respite, the burnout, because I think those are the same words that we saw 10 years ago. It's still existing because as we progress, the demands for the care increases. As the child grows, I think the demand increases as well. So I think that's something we need to look at. But I've got a very important question here that's come in. It's slightly difficult, so I'm going to leave it open. It's actually from the media. And this is a very key stakeholder in my mind that we need to talk about. Do you think the current coverage by insurance companies in Singapore on rare disease is adequate? So I don't know whether it's adequate because I don't even know if there is anything. If not, what can be done and what can be the incentive for them to expand the coverage? So that's from the media. Kenneth, would you like to take it?
Okay, I think at the moment they do.
You're breaking up, or is it me? Yeah. I think your mic maybe has.
Oh, can you hear me now?
Yeah.
Okay. So on insurance coverage, okay, at the moment they do have some coverage, but there are also some so-called clause within the insurance that in a way exclude rare disease patients. Take for example, once the insurance get into from the effective date, that means the date that the child has been covered. Okay, there is a clause to say that there is a 24 months waiting period for congenital or hereditary conditions. So if your child is diagnosed within that 24 months, the insurance doesn't cover. Yeah. And then recently there are also policy that come up that covers certain congenital condition or this, which is good. But then overall to the industry, the healthcare insurance has moved towards like more of to like a automobile insurance coverage already. Like you don't claim, you got NCD. No claim discount. Yes, no claim discount. But then look at our situation. How not to claim? Our child has a condition where regular treatments is required in the hospital. So forever, I will not get NCD. You know what I mean? Because I already have a child, with conditions. So these are the things that has to be changed. And then, of course, to advocate and lobby for extension of coverage to rare disease, or I think it's more of a business decision. It's beyond we, the caregivers or the patients, because we do not know if they change how this will impact the entire insurance industry. Okay, and then it might also impact the regulatory environment within the industry. So it's really something that is beyond us. All right, and then it probably will be a good way that we can see that it's a top-down approach, a top-down approach from the regulators to the industry, and then we can see how we can actually come up with a better coverage, a kind of insurance plan that include all conditions, and regardless is congenital, hereditary, or whatever. Yeah, because we have to understand that our child are born with condition without a choice. It's not what the parents want. It's not what the child wants. But then again, the industry, wherever we go, it's like we have been penalized for having a child with conditions. It's not just insurance, but in many other areas. Yeah. So let's come together, and again, it's engagement. So multi-stakeholders engagement can also include the industry people.
Insurance.
We sit down,
Insurance.
yeah, because the challenge we always think of is, is about sustainability. Doctors' responsibility is to diagnose, but it's not their job to get the fund for the treatments. The pharma is here to make money. If without income, they cannot further improve their drugs. They cannot, do research, to treat other conditions. Yeah. So research, all this all require money. Yeah. So it's about coming together, how to build this system. Yeah, ecosystem also required, feedback, required, all of us coming together. So for a patient or family's point of view is sustainability, how to sustain. My child is put under treatments. It's a lifelong treatment. How to sustain. Without a proper funding mechanism, we can't have, we can't sustain. So what's next for us? Yeah, so these are all the challenges that we have to sit down and talk about it. Yeah.
Yeah, so I think it's a very good end, right, Kenneth? You just brought us to a very good stopping point. What we're talking about is sustainability for rare diseases. And the thing is that would include the inputs from all the stakeholders, because we're talking about sustainability of life. We're talking about sustainability of payment plans, sustainability of care plans. So I think that's a good approach. And I think what we're going to talk about is next, maybe internally, is how are we going to do it? Who are we going to engage? I'm going to leave 1 minute out there for anyone who's watching to drop us some questions. But in that time, I'm going to just move around our panelists and ask if there's any, last thoughts here before we close. So maybe I start with Dr. Saumya. Yeah.
No, nothing to add, but yeah, I think, we just need to keep pushing. I think that's the key. And slowly make Rarity a reality. I think it's beginning to happen.
Yeah, we're going to use that for a while now. Yeah. So Dr. Goh, any thoughts?
Yeah, so I guess for my side, it would be early diagnostics and connectivity. That's the word I would also add to the ecosystem, because we can be the lever connect Singapore and Thailand. In fact, we recently had a rare disease summit in Thailand, and we hope that through similar summits, we can connect across ASEAN to also advance the agendas that we talked about today.
Seng?
I think we have more or less touched on a lot of major points already. The key, I think, that I just want to reiterate, I think in Singapore we have to have a bit more data-driven approach to all this conversation. I think that's important, and we have to start building up that database.
Wonderful. Yeah, so I think we've summed it up pretty well. Thank you, Simon, for sitting there so silently with us and supporting us. Preeya, before you leave and your last thoughts, let me tell you where we got all of these ideas from. We got Rarity to Reality from Thailand, because that was your summit in January. All right, we're taking your work forward. Yeah, so with that, I think, we thank you all. I see you tomorrow, Preeya. Thank you very much for joining us.
Thank you.
Happy Rare Disease Day and week. I hope we will meet again with better clarity on our reality soon. Yeah, so I think let's meet again. Thank you, guys. Yeah.
Thank you.
Thank you.
Thank you.